You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
I thought we've forgotten who we are. Explorers, pioneers.
We're back. So I was behind an episode, so that was 36, not 35. And actually we went till May. I didn't end in January. I don't know what I was seeing on YouTube, but
I thought we said April.
The last season.
Yeah, it was May of this year is when we quit, first week. So YouTube was showing me different stuff. Liars. Probably algorithm. Definitely a Democratic algorithm.
It's a conspiracy.
Yes.
That's the new conspiracy we should start throwing around. Is it subtract?
Updates from last week. My runner I haven't seen. I'm assuming that means he's better.
I thought you did.
No. I saw him the day after.
That's right.
He was like fine.
Yeah. And then he raced.
Like, I'm here because I'm supposed to be, yeah. And he raced, won, wasn't competitive. He did get boxed in. It was like 10th for like the first half mile or something.
I guess they've had sectional since then too, which he also won that race.
Yeah. So he's doing good. Haven't seen him. Hopefully he's just not grinner and bearing. I doubt he would. Your runner?
Yeah, she's doing great.
Or runner, CrossFit.
Runner, CrossFit,
Yeah.
High Rocks competitor.
Yeah.
She's good. She
Hybrid athlete?
hybrid. Anything with high in there, we're just gonna start putting it.
I've only ever seen that High Rocks word like twice, so I don't even really know what it is.
High Rocks is an endurance-based CrossFit.
It's like you do some I think it's like a 1,000-meter row, and then you have something to do that's like weight based in the middle.
Yeah.
So like it's like 1,000
Like
meters.
stationed.
Like one of them I looked up is like you have a 1,000-meter row, and then you have like burpee broad jumps for like 100 meters, then you're back on a rower for like 1,000 meters, and you got
They're always standardized. Like this is the workout that you're going to compete in, or is it change every day?
Most of the time.
Yeah, okay.
But it's that format.
Yeah.
So no other updates. She's good.
Yeah, she did some lateral runs, like some shuttle runs, but she was worried about that. Yeah, she has no issues.
Are we talking like elementary school PE shuttle run?
I don't know. I didn't ask what grade level shuttle run she was doing.
She's talking
I'll do that
about
next time.
Napoleon Dynamite snow boot shuttle runs. That's what I'm picturing in life. A lot of squeaking. For any patients listening, we just changed up the functional health coaching model in here. So now it's a monthly based membership. You can go to chirofarm.com, whatever, I don't know what it is, functional health coaching, something like that. Find out more information on that. You can sign up in office or online. So also there's a form at the bottom. I don't know who's got their vibrator on. Somebody, maybe it's me. No.
It is Alex.
Alex is getting his reminders to take his prostate medicine. But yeah, there's a info form down there if you do have any questions, because a lot of people just kind of want to know more about it. It's bullet pointed, and if you ask for a question, I'm just going to be honest, I'm going to probably tell you bullet points because it's pretty low. So yeah, love to get more people involved in that, but let me know if you have any questions for real. Presenting today, Seth's the lead. So
Heck
what's
yeah.
the case about?
So this one's going to be outer knee pain.
And again, we're being a little more broad. So what would be so go real fancy. What would you diagnose this at if you're being a fancy doctor person?
LCL sprain.
Ooh, that's not that fancy. But trying to be more
Fibular
broad.
or lateral collateral ligament.
And the reason that we're saying lateral knee pain is in our doctor's meeting last Thursday, we went over lateral knee pain for this case and then what Alex is going to present on. But we started with differential diagnosis, and what we come up with like 12 things.
Mm-hmm.
And yeah, LCL, which this, is I would say not a classic mechanism, but a classic presentation of LCL disruption or, sprain. But in there we have what? LCL, lateral meniscus, tibial plateau fracture. We put trigger points in the differential diagnosis because they can be solo pain generators outside of any pathology. Lumbar radiculopathy or pseudoradiculopathy.
Peroneal nerve.
Peroneal nerve. What else do we have on there?
Cutaneous.
Yeah, cutaneous.
Nerve, peripheral sensitization.
Meniscus.
Meniscus.
Our big one was just a list of trigger points that referred there.
Yeah, and a lot of people are like, well, it's not really a diagnosis. There's a lot of people running around with, and this is what we know more now is you get an image on somebody, everyone knows this. Let's say they have a tear in their lateral meniscus. When did that happen? Is that even the pain generator? Then the trigger point could be the compensatory mechanisms create the pain. And you get into this whole discussion, and I think they should be a primary, diagnostic feature. So all that to be said, get after it, Seth.
Let's do it. All right. So this case, I've got a 58-year-old male with left outer.
These case or this case.
This case.
We're losing all West Coast viewership right now.
I was like, Jesus.
Sorry.
So this
Sorry.
This case.
on the prescribed plan I'm looking at.
Sure.
58-year-old male with left outer knee pain. He noticed this about 2 weeks prior to this first visit. He was skateboarding, stepped off hard into an incline. Mind you, he took like 18 years off of skateboarding and got back into it just because it was something he wanted to do, I think, with his son.
Okay.
So he now skateboards.
Have you guys ever seen The Secret Life of Walter Mitty?
Yes. Yes.
Just like gets out there and starts like going.
If you want to go kind of body type, I wouldn't say it's like your normal skater look. He's got he's done very well. He's lost like 100 pounds or something like that, I think, in the last year and a half or something. Went through some like traumas past. So now he's kind of getting back into it just with walking and then getting into some trail runs, which is actually where I met him, was actually at a trail race that we worked. But yeah, so into an incline. So he's trying to do some trick. He said that he's just trying to learn, I guess, like how to get the skateboard up onto the side. I don't know, a little ollie type thing. I don't know. I don't really know super like skateboard fancy terms, but he's trying to go up and he kind of got nervous. So he kind of got stepping off. And so he was like hard planning because he tried to get some speed into the ramp, hard plant to an incline. He noticed he has some radiation with his symptoms up into his lateral thigh and a little behind his knee. He had some swelling that he noticed after this incident about 2 weeks ago. Sort of went down, but hasn't really gone down too much since it happened. He notices that the worst pain is when his dog actually comes up and bumps into the outside of his knee, and he gets like a shot. Yeah.
Worst week manual.
Boop. Which he gets like a radiating symptoms like up again into like the I guess lateral aspect of like his thigh.
Just real quick, I was never told that in grad school. I don't know if you guys were like in a class like ligaments have referral patterns.
I don't remember learning that
The
either.
LCL's referral pattern is like up into the lateral quad or vastus lateralis. So it's just like typical one. If you push on, if you have point tenderness there, you might get a referral up and you're like, ooh, that's probably LCL.
Which initially my first thought was kind of like we're dealing with a nerve, because when I hear like a little shocking symptom, when you get smoked really quick in an area that the nerve is pretty close to the skin, I'm like, okay, we're probably dealing with a nerve. But then when he points to it, I'm like, there's not really a nerve out there into like where it radiates up into. The other thing that he complains about is he does some like stretching routines when he's in the shower. And yeah.
How much did you ask about that?
I did not go into detail. I just said, so when does it hurt the most? And he's like, every morning I do some type of stretch routine in the shower. And that's kind of how that came up. So it was a pretty broad question that led to a very specific time of day. So he notices that when he squats down, he does get some pain in the outside of his knee. Outside of that, he has a little bit when he walks, but nothing really, except for mostly when he notices that his dog, because I think he has 4 dogs at home. So whenever he walks them, like all of them are about like knee height, and one like just smokes his knee. Prior to this event, about like a month before, he clipped a tree mountain biking, broke his left big toe, and fractured a couple of ribs on his right side. Past surgeries, rebuilt collarbone in 2023, gallbladder removed in 2020, and a melanoma removed in 2000 in his mid-back. And his main goal, seeing me today, was he wants to be able to run the Endless Mile in 3 weeks.
Which is a 1.1 or 2 mile loop that you can run for 24, 48, or 72 hours.
And he did the 72-hour one, and his goal was 100 miles.
Did he do it?
He got 100 miles in. So pretty sweet. So watching him walk, a little bit of, I would say, bowing of his legs when he walks on both sides. If you want to say almost like the cowboy walk, where like kind of like a wide base stance, like knees, I don't know, just a varus kind of stress to him. No extension of left hip. And then he has a foot flare on his left as well. Top tier, dysfunctional, non-painful on most things, all cervical and upper extremity patterns, multi-segmental flexion, extension, right rotation, and single leg stance on the left.
for patients listening, when we say top tier, that's looking at how you move in general. So if somebody comes in with a knee complaint, we're not just landing down on the table, doing classic orthopedic tests, poking where it hurts, and giving you a diagnosis. We're trying to, in particular, in this case, yeah, there was a trauma, but if you listen to the beginning and you're familiar with like an LCL injury, if you looked at like a football player that's going to have an LCL tear, a soccer player, you'd usually think like some like inside to outside, like blow on the knee, right? And you're going to think bend the knee to the outside. Well, in this guy's case, he just, like Seth said, he had like a hard plant, which doesn't seem at all like that would be even in our differential diagnosis, which brings in things like tibial plateau fractures and things like that. But I don't know how much you think it weighs on it, but having that varus kind of knee formation already, and then you're stressing all the time. If you take a hard step, I mean, maybe there's more extra lateral force there. So just general broad-based movement. Seth saying some of those hurt, some of those don't, and some of them are dysfunctional.
So that's kind of what we talked about in our doctor's meeting, was actually like how many people are actually walking around with a degenerative LCL sprain.
Yeah.
And based on his age, it's kind of something that popped into my head of like, he could have degeneration here, and then now it's just getting ticked off because he's doing something that's out of the ordinary.
Which, again, drives me nuts. And if you're a patient listening, like, look at the image report or ask the physician that you're dealing with. It drives me nuts when they say like a sprain, but it doesn't say acute or degenerative, which would be called off edema, which is what they're usually calling things off of. Mm-hmm. You can also have, less echoic response, it could be thickening, all these things, and they just might call it a sprain. You're like, well, is it old? Is it new? And that's kind of what we were just talking about. Mm-hmm. So that drives me nuts on the impression of the report. It's just like sprain. New, old, what are we talking about?
Yeah, I feel like they usually do that on a fracture, but they don't on the soft tissue side of it.
Like stress fracture, yeah. Or they'll call like signs of recurrent healing or non-healing or something like that. But yeah, I feel like getting impressions in general. Which is funny, did you guys see the impression from my patient that went to the open MRI? The MRI that you can just go on your own, no referral.
Had grades on there for.
Yeah, the report was huge.
Yeah.
I don't think the read was awesome, but the report was just massive, which is kind of funny for this cheap, open access MRI. The report was like, 10 sentences long. So, yeah.
Going off of that as well, I know it's kind of side note. I didn't realize that, was it the stress reactions? Is that what we were looking at? Had different grades to them or something like that? There was like grade 1 through like 5 or something like that.
That's based on percentage, right? Like percentage
of healing, you're saying?
No, progression of basically how much the stress reaction like going from the periosteum into the trabecular formation. Because that gets in, I would assume, we could look it up real quick. A grade 3 would be where you can probably pick it up on an x-ray when you have that 60%. So let's keep going.
I'll keep going. So just a recap, top tier, dysfunction non-painful, all cervical upper extremity patterns, multisegmental flexion, extension, right rotation, and single leg stance on the left. He was functional non-painful with left multisegmental rotation and single leg stance on the right. And then drop him down, inline lunge, dysfunctional non-painful with right knee down, left leg up. And then I tested a little bit more just because there was a discrepancy in rotation. I used lumbar lock to see if maybe anything with like his mid back. He was dysfunctional and painful bilaterally there, just in his back in general. I mean, it's very, very stiff, which I'll get to in terms of palpation. But I also used it as well for just a passive knee flexion because he said he gets pain with squats. So I just used it as a passive knee flexion to see if it was like load that really like bugged it, and he had no pain when he did that. Other exams, so orthos, varus stress was painful. Thessaly's was a little painful when he rotated out. I did Noble's test, which is just a little bit for like some IT band stuff. If you like, flexion extension, poke on the IT band, sure, whatever. But more so just kind of compressing the bursa that's underneath there and then taking them through extension. No pain there.
What's Ober's?
Ober's.
There's a sideline, pull the leg behind it in the hip extension and let it fall.
Oh. So what's the...
That's IT band.
Abduction, is it?
IT band is Ober's.
What's the one with abduction?
Internal rotation. Is that Fayer's?
Fadir?
Fadir? Yeah.
Where you're like letting it hang in and seeing.
Sideline?
This shows you how much
There's
matter.
There's Faber's, Ober's, Fadirs, and Fayers, and then Legaire in the air.
In the air?
In the air.
We got
Balot. I did not do ballotment. I'll just tell you that.
So real quick, while we're making fun of orthopedic tests, but the grading for stress reaction to fractures is grade 1 through 4, and then 3, 4 when they're visible on X-ray, and then showing that it could be fully visible on MRI, which of course it could if it could be seen on X-ray. Which just starts out with periosteal edema, and then moves into bone marrow edema, and then moves into basically further progressions of that. So yep.
Sweet. Then I went over and did a little bit of palpation. So easiest way to check kind of like LCL is put it in like a Faber test almost. So you kind of put heel, or I guess put it like a little, how would you put that? Quad lock? I don't know how to say that. Bend the knee, flex it, lay it on the other knee. And palpated his LCL from there. Painful. And then lumbar orthos, negative. Couldn't reproduce anything. Just looking for any like low back referral. Checking those out. Couldn't do anything there. Presentation, if I had him prone, a little bit of hollowing of his left glute. And our last intern, Patrick, was in the room, and he even picked it up. He's like, that glute looks different. So when you lay him down, his left glute's just like sunk in. It's not as full as the right one. So it's kind of something I just took into note.
Did you ask him if he'd have previous prosthetics and had a failed one on one side?
No.
It was 2024. I don't know. Ask those questions, man.
Range of motion, external rotation of his left hip was limited, and then he had limited ankle dorsiflexion on the left, neuronormal, and then palpation-wise, limited an extension of left hip, tibial ER on that side, TL thoracic and CT junctions. He had a trigger point in lateral gastroc, vastus lateralis, and then tone of his left glute musculature. I just put tone of like whole musculature on that left side because I wouldn't say it was like trigger point, but I'd say it's just like holding on for dear life with the hollowing there. Functional audit, I actually used the glute as one of mine. I had single X stance on the left, and then his central stabilization strategy is pretty bad. Pain audit, varus stress, and tenderness of touch. So I came with my diagnosis LCL sprain. Treatment, day 1, I did a little bit of Graston or instrument assisted over the LCL just to kind of promote some healing. Because again, it's been going on for 2 weeks. It's kind of promote a little bit of something going on there. Looked at 3-month supine for his IAP because laying down on his back, he has a pretty significant like rib flare. So I just wanted to see like how he breathes in general. He's also a pretty tense person. So like whenever you're moving him around, I mean, it's like kind of fighting a bear the whole time. He can't relax. I'm like, hey, just let your leg go. And that actually makes it worse where he just like holds his leg up in the air for you. And I'm like, all right, do what you were doing before. So then I wanted to attack, honestly, his left hip just because I noticed the hollowing of his left hip. So I knew that he had a little bit of trouble, I guess, absorbing some load on the left side with the mechanism of injury that he has. So I was like, let's try and calm down some musculature on the hip. So I put him in a 5-month rolling position. He could not roll. So I lay him on his left side and have him like just push back into me, and he literally can't produce like any force into me.
So when you say hollowing, you're saying like atrophy of musculature or active like contraction?
Active like contraction. Because that was the thing. I was like, can you get this to relax? And he can like slightly for a second, but I mean, for the most part, he couldn't like eventually, he couldn't just like let it all the way relax. So again, put him in 5-month sideline on left side, have him push back into me, and he can't. So like we can't even do like step 1. So then I was like, let's try and roll you a little bit farther and see if I can't get a stretch on it. And then you push back into me. He still can't do that and actually catches a cramp on like his like right hip trying to do this. Which while we're doing this, you can feel him using his right leg the whole time in order to push back into me. So I was like, okay, well, how can I do something with this left hip in general? So I put him in actually a little star plank on that left side and had him just hold, which he started kind of seeing like, okay, hey, my left glute like burns holding this position. And then we worked a little bit trying to get him to like lower down in that position just to get some stretch on it. And then taped his LCL, which I did a little bit different than you described in our meeting, which I just put a piece of tape down kind of lower third of the thigh all the way down to like the top third of the calf on just the outside. And I took a piece just because I noticed he had a little bit of like tibial external rotation limitation. I took tape and wrapped it so it kind of almost like pulled it into external rotation to kind of help offload his LCL a little bit. And it's also just some pain relieving just because it's over the LCL. So adjustment, CT thoracic, TL left ankle, homework, send him home with star plank and IAP work. Second visit, which this technically was actually visit 4, because the second visit he came in, we worked on his neck because he got laid back in a dental chair and had like, I don't know, his neck got smoked from it. And then third visit came in with some like right low back complaint. He got up that morning and I don't know, he like couldn't hardly stand up. So we worked on those 2 things. So second visit, knee feels much better today, which I would say this is probably a week later. Did not feel it while skateboarding this week. Still a little tender to touch, but nothing like the first visit. And then varus stress is still slightly painful, but he said it's like a 1 or 2. His glute, he said, is super sore from the exercises that we sent home. So the next visit I did some Graston again, some IAP like review and star plank review. And then we moved into a rotational plank because he still couldn't do the like sideline position. So I moved into a rotational plank to see if he can maybe use his elbows as a little bit of like a prop to work on the left hip. So I sent him home with rotational plank. Third visit, no tenderness to touch this time. No orthos are provocative either. And then treatment, reviewed IEP rotational plank, did a hang position to start kind of getting his foot involved because, again, we're still dealing with a fractured toe on his left foot. So he's still trying to offload his toe a little bit. And then worked on some 90-90. Fourth visit, which how far do you want me to keep going down? Because I've seen him probably like 10 times. And I did to like visit 5 is kind of where I stopped for this. But fourth visit, did some low oblique this time with rotation because I wanted him to start kind of seeing what it felt like to use his foot and lower leg in order to rotate around his left hip as we're instead of just kind of like pivoting around his knee, more so using his hip. Couldn't figure out how the life of him to do that, which I kind of just like helped him like pin his foot down. He figured out what that felt like and was able to kind of do it from there. So sent that home with him. And then fifth visit, I worked on some rotation just because he had that discrepancy. If I'm not mistaken, it's to the right. Yeah, right rotation. So I did a diagonal RDL because I know it's going to his left when he's doing a like some rotation to the left. But then also did a half kneeling kettlebell rotation to the right because it helps work on some like left hip extension and right rotation, which is 2 things that he's lacking. So homework, I did some diagonal RDL. But after this visit, this was, I think, this was Thursday. No, this would be Wednesday morning. I saw him, Wednesday morning. And then he started the 100 miler for the endless mile on Thursday. And on this visit, he had no pain, was ready to go. I saw him again Friday, which it was kind of just like a little bit of like a tune-up. Let's make sure you're still feeling okay to get through this thing. He was like 50 miles in when I saw him on Friday. And then he hit his goal of 100 miles by the end of Saturday.
Okay, so let's break that down for patients listening. Guy came in with lateral knee pain from stomping a weird landing or repeated landings, skateboarding. Why did he choose us over somebody else?
He just talked to me at a race and liked what we did. He had heard good things about us.
So we've seen him in the past. So he's an old patient. Seen him for like Achilles stuff and things like that. So have a history with him, and then we're in his face. So you met him, pertinent history stuff. Like had he ever had knee stuff before?
Mm-mm.
Yeah. So there's like no big orthopedic injuries. It's kind of like, well, what's going on here? He's got all these things he's wanting to do. Again, just trying to break it down for patients listening. Like the big findings aren't that. In my opinion, that Seth thinks it's an LCL sprain. It's like, you had a weird little injury. Let's work on your hip and kind of these other findings around it so we can alleviate, undue stress on that thing that might be occurring all the time, not just, in skateboarding. It's probably hard to pick up the translation of a lot of, if you're a patient of when we say things like, high oblique sit or low oblique sit or 5-month sideline. But basically, if we had to really break this down, is this guy, like Seth said, has a hard time dampening load around his left hip, and in particular, like sucks at creating a rotation or like stopping a rotation on that side. So then if we had to take the two mechanisms on the side of your knee that might check rotation, one of those being the LCL, like it might be getting beat up because of that. I think that's why Seth was working on that. And then in terms of like future plans, like you said, you've seen him a bunch more times. Like, is there anything that you think he should be doing in terms of like, lifestyle shifts, in terms of like a big goal in here is I think we try to take whatever we're working on in the immediate realm and then say, hey, we're going to apply these concepts into like what you're doing cross training or something. Is there anything that you're like, if I see this guy consistently over the next year, like this is what I'd be working on? Anything different, or is it just kind of same theme and just more of the same, build it up?
I know sometimes we kind of lean heavily on like potentially just being like, oh, he just needs to go like into a gym or something like that.
Mm-hmm.
But I do think that is something that he would benefit from because he doesn't do that. His only form of exercise is literally just like, so he started walking a mile because if I'm not mistaken that someone like in his life passed away, went through like a hard block there where he got like super depressed. So his goal was just to get back into it, was just to start walking a mile every day. And I think every month he added 10% to that.
And he had been to a point where he couldn't run anymore. Because he had this recurrent Achilles thing that I think he had a stress fracture, a legitimate fracture at one point in his foot. And like he had all this stuff. And that's, there for a while, it was like every time we saw him in a race, he wasn't racing. Because he'd walk up and be like, I can't do this. And then he I don't know if he took time off or just started walking instead of running. I don't know what happened there, but.
Yeah, he took like 2 years off of not doing anything just because of life.
Mm-hmm.
But yeah, so he's up to where he's like, so his exercise consists of, he does longer like ultra trail runs with, I would say, minimal running during the week. And like a 1.5 mile walk is like his like big form of exercise along with skateboarding. So like I think that's something that will like play really well with the gym is just like honestly like you sometimes have to set yourself up or get the joints, tendons in those areas to like actually be ready to handle the stress that you're putting through it, right? At least increase the muscular endurance through there.
Because again, it sounds really cool, right? I got my knee pain, he's back skateboarding or in this $100 race. We'd be setting him up for a bigger fail if we're just like, oh, we got you moving, you can decrease pain really fast. And then we're like, oh, this guy is undertrained for the stuff he's wanting to do. He doesn't have any general strength training. He's aging up. And then pretty soon we're like, we're just another person that's, maybe better than other offices at getting people out of pain and moving, but we actually didn't like push them to be like a healthier person or a more resilient person. So I think that's something that's highlighted is in our framework. We're never just like, let's get you out of pain, get you moving, get you do that race. That is a goal. But like, hopefully that's motivation. And then we can kind of build off that to like, hey, we did get you moving a little bit different. I know you feel better. Like we think you got to work on these things, whether it's something that we're supplying or just frameworks and concepts that we, educate them on. But that is an extremely common theme in the ultra running community. It's just, you're only doing that thing or you're vastly underprepared for the competitions you're doing. And I fall into that category sometimes too. If you're just going stuff and I'm going to, grin and bear it. Yeah. Cool. Anything else on them?
He also told me that he prints off every time all the, whenever I send him like or rehab my patient, he prints off all those because he's like, I want to add these to my routine. So he goes, I kind of get up and even though we haven't done these in a while, I still kind of do stuff from the very beginning. Cause he told me, he's like, I know, because he said, I can see the difference from what we've done in here to when I go out and I do run and I do walk. He's like, I can tell that there's something different about how I feel when I go do them. And he's like, so I just thought, well, if I feel this good now and I continue working with you, what could I feel like in a year? So he does have like a long-term play, like in his mind. And he's like, I want to get to where like we start taking this stuff, like to some weights. I mean, he mentioned about doing some weights. That's why I brought it up.
That's intrinsically motivated. You didn't tell him to do that. He's also setting up an amount of time with stuff that we would all be like, well, that's not really changing a whole lot. It's just kind of like neurologic shifts. But then we can just do what? It's like say, hey, we don't want to add more time. We just want to slowly progress those drills, challenge more, use the same amount of time, whether it's daily or a couple times a week. And like you can literally start to really have big change. And that's the tough thing is when somebody's looking for quick fix, get out of pain, get me out of here. And there's a bigger lifestyle thing. Like you don't, they have to come up with the idea. So he's already literally telling you that. So it's teed up, which is nice.
And then the other thing is you mentioned like stuff that we're like going to continue working on. So his mid back, I know that's something I brought up just because I mentioned his central stabilization strategy, but I could throw that on anybody almost, I feel like. But for him specifically, he had that melanoma removed back in 2000 around, I would say, like if you want to get specific, T6, T8 range. Mm-hmm. And he's actually like tender over like where it got removed on the left side. Mm-hmm. And I would say that's probably one of the stiffest spots for him, especially when he tries to create rotation, which the half kneeling, like kettlebell rotation, he can do it if he's just body weight. Mm-hmm. I add a 5-pound weight to that. He can't hold that up at all. Yeah. So it's honestly just like getting him there in that position. And then I honestly just apply a little bit of pressure. But that kind of goes back to like, what do you start with for like the most like functional piece? It's like to a point, like I got to treat the injury here, like almost like touch them where it hurts, treat the bigger underlying thing. But then it's like you mentioned, do I set him up for, a potential, not catastrophe, but like
a
fall because he has more confidence in the left side, even though we didn't actually address like, hey, how you stabilize around your core is like not great. A mid back super stiff.
Right? Specific things you're working on in general exercise, right? And that's like the key to what we're doing. Is like, like everybody's got saying like, my left hip doesn't move like my right. I should work on that more than I do, but it doesn't mean that I'm just doing mobility stuff for 15 minutes every day. Like you could do that sometimes, and then you can program stuff specifically. And it's, in my opinion, it's not that I think we kind of get in this discussion of like load management, weight room fixes everything, quit doing your stupid mobility stuff. It's like, that's not completely true. I mean, there's stuff that you have to do tissue work on, and, things like that. So yeah, I think it's a little bit both, but that's the end goal for all of our people is a healthy person that's not in pain. And, that's rarely just like get their T-spine moving or their hip moving to sit them out of the office.
So the other thing, the reason why I started working on it is because he said that he went on a longer run this weekend. And started feeling like his upper neck or like upper back between his shoulder blades. Whenever he started like getting up to a jog, he started having like pain up through there. In which, first thing I started getting like nervous. I'm like, you have like any heart issues or something like that. But then like I put him to like a little FCS test, which is just 90 seconds of can you split the weight 75%. Mm-hmm. And I actually did it like half his body weight, and he barely passed. I mean, like. At 90 seconds, he was like going to the ground.
So Seth's saying he took half of his body weight, split it in between 2 kettlebells, and then had him walk like a figure eight or around the room for 90 seconds and see, hey, can you do it? Does your grip fail? Does you just like melt into the ground posturally? And you should be able to do 75% of your body weight split between 2 implements for 90 seconds with like not a big struggle at all. Then there's proxies if you have grip issues and stuff like that. But yeah, it's a good test overall. All right, so not a full case presentation, but you have a similar to had lateral knee pain or knee pain?
Yes, lateral knee pain, and it's not the case we discussed on Thursday.
So just give us for this instead of the whole thing, like give us similarities. Like, is it, is this an LCL case? Is this something different? Why they come in? Obviously, it's lateral knee pain or knee pain. And then, what differed from Seth's, even though, because again, what I'm trying to highlight for people listening is all of us in the room could have lateral knee pain. We could all have done something. I tripped on the trail. He was skateboarding. He was playing flag football. You've just been training for a race. And all of us have lateral knee pain. We come into the office. I mean, we could all be very orthopedically minded, poke on it, do orthopedic tests. Everybody's got an LCL sprain. Mm-hmm. And then, what's that mean? So give me the rundown on that.
Yeah, so this is a 43-year-old female, former collegiate runner. Her and her husband both were, and then now her kids are pretty high-level runners as well. They were on vacation in Colorado, and she had this. Hers is also an LCL sprain. Hers was a traumatic singular incident where they were walking the Manitou stairs. Mm-hmm. The last stair, she fell. Coming back down.
It's like literally how many is it?
I mean, I think it's 2,300 stairs.
Yeah, something like that.
And she's prone to be a little clumsy, which looking back on her original intake now, I remember
2768.
27. Yeah, it's a lot of stairs.
So
Actually, technically, it'd be
she made it
5,400 because she went up and down.
Oh, she fell on the last one down?
Oh, yes.
Oh.
She
Oh, no.
fell the whole way.
No, the last stair.
The last stair
Coming
before the
back
parking
down.
lot. Yes. Yes. Which she had also had a fall right before that. And she, I mean, clumsy, but she's not a motor moron,
Mhm.
to put it lightly. But now looking back on her intake, I did make note that she has major visual discrepancies in visual acuity from left to right, legally blind in one eye, and she does wear glasses, but sometimes doesn't wear them when
Make
she
sure you see
runs.
that last step.
So there's also a possibility. However, so this was 2 weeks. No, it was a week after it had happened when I saw her. Generalized swelling around the knee. She had not been able to run and had a bunch of abrasions around it too. So she's also, all right, this is sore because I landed and cut my leg up. But so initially she did have some pain on orthopedic tests, Thessaly, Apple's compression, no laxity in the ligaments, just pain on that outside by the LCL. And really not a true functional audit at this point because she had fallen and it was a singular event. And so we were really focused on trying to get the swelling out. A lot of her pain and limitation was in knee flexion. She had pain with flexion and extension, but she could tolerate knee flexion with gapping, putting a bolster behind her knee. So we used that to help get swelling out, instrument assisted soft tissue. And then I had just sent her home that first day with knee gapping flexions. Over the first few visits, we did some more maneuvers of pumping that fluid out with knee gapping flexions, plantar flexion sits, had done some voodoo flossing around the area to continue getting the swelling out, and we taped the outside of her knee. And so for her, I saw her, I guess the actual trial of care was 12, 13 visits over the course of, that was early July. The last time I saw her was late October. And we were at the point where she had gotten back to running sometime in August, late August. So 6 to 8 weeks before she was back to running again, and gradually increased that. But over the course of starting to introduce load, kind of similar to you with him, was that I went to a side plank so that she could get some isometric load on that LCL, and then progress that from there to various forms of lateral stabilization in lateral squat with diagonal single leg deadlift. And she's one that kind of similar, different in running because she's mainly road running, but she doesn't do any sort of cross training, any resistance training. And she had gotten to where she was a little more open to that because her daughters that had been in here had also, they could benefit heavily from doing some of that. And they've started to do some of that in addition to their training. So she got to where she was working out with one of her I think her assistant coach twice a week and doing a lot of the things. Really, it started by just doing a lot of the things we had shown her in here. And then now she's at the point where she's doing box step ups and lunges and skater jumps, things that we basically just progress those forces up to including some plyometric. And she's always had she mentions later, I've always just kind of had general knee pain going downstairs, running down hills, getting up on and off the floor.
You say you've always just had general weakness?
Yeah. No. Well, she has not loaded her knees, in any kind of way outside of running. So she's not getting a lot of loaded knee flexion at all. And she says, I'm just not, I don't feel like I'm old enough for that to be a thing. And it's kind of embarrassing when I'm getting on and off the floor, like talking to because she teaches, she's like talking to middle school students. So I get down their level and I come up and getting up. So long story short, she had started including some of those things, and they were uncomfortable at first. She was a little resistant to any sort of tempo squats, that kind of thing. So we backed it down to starting with a bear crawl, where she could get some loaded knee flexion, and then to a sled push, and then eventually to where she's doing some tempo goblet squats. And the last time I saw her, she she did a 9-mile run, which was the longest she'd done all year. She's running about 20, 25 miles a week. She's doing a half marathon in a couple weeks. Her and her husband are. And and now she's still continuing to strength train twice a week and feels a lot stronger doing those things. So, it was more of an acute trauma that needed to be addressed. She didn't necessarily have a functional or dysfunctional issue that led her to that problem, maybe other than not being able to see. But we were able to say, hey, I know you want to continue running for the foreseeable future, and something that I think that will benefit your longevity in that is some form of resistance training outside of the sagittal plane, more than your body weight. Because I feel like I've heard from her, from other people in that age bracket who have run for half their life, is that, I do some resistance training. I do some body weight squats, and I do some, I've got some 5-pound weights at home, and which we all know is not enough to stimulate any sort of buttressing against the forces that she's going to experience when she's running.
Buttressing, man, I hadn't heard that word in a minute.
Yeah.
Go for it.
You can steal it. You can use it. I'll copyright it. You can give me a couple $1 at home, put it in the jar. So that's where she's at now. And I don't think we don't have an appointment on the books necessarily. It's more of now she can use me as she needs me. But
Well, I was looking for the chart. It's on my hard drive, but you kind of said this happened to her in July.
Yeah.
Right. And then we're first week of November now, or first week of November.
4 months.
So it's also, if we look at, say somebody has an ACL surgery, right? The earliest NFL players getting back is 9 months, which is pushing it, right? And a year is like the classic, like ACL return to play. So even with, if we graded those, grade 1 for sure with, Seth's case, I don't know.
Maybe 2.
Grade 1 plus 2 over here. So there's a timeline too to when we expect that tissue to be more resilient just from a healing standpoint. You can throw all the loads at it you want in the world. Doesn't matter. The thing still has to be able to respond physiologically. Mm-hmm. You can just help. There's 2 things you're helping promote. You're helping promote a pro-inflammatory response when you load it or do soft tissue. Second thing is, which we talked about with like Keith Barr and a bunch of other people. If you look at Tom Smyers, is like the actual lines of stress that you're laying down across that area are a pretty big deal for expressing a 4-range of motion that can buttress the forces that are applied against it in the future. And that's something I don't think it's talked about enough of. General PT, right? If we leave people severely underloaded, then maybe we didn't you get 4-range motion on the table, and then you don't apply like the stressors when you're up off the ground, like you said, outside of the front to back or sagittal plane. And if we thought about like the lines of tissue just on an LCL, like how are you going to respond to sagittal plane motion when you have to control coronal plane like shift in there? So it's something that gets missed quite a bit, even though I would probably agree like a lot of return to play criteria for like post-op PT stuff for an LCL is going to be like skater jumps and lateral bounds and stuff like that.
Yeah.
But I don't know how much that's getting stressed. You know what I mean? So I think that's a good point of timelines matter because we rarely see people, getting around 10 visits for us is like maintenance stuff. Right? So like you have to take that into account with the diagnosis. Like, oh, you have legit trauma versus like, hey, I think you're just having pain from, like you said, a trigger point or something. That's wildly different. Doesn't mean we kick you out of the office if we think there's stuff to work on. But again, that's taking into account with that exam. Any other commentary just on knee stuff in general or either one of these cases?
There was something to note when she started to get back into running. She was very hesitant about it. Mm-hmm. She loves it, but she doesn't want to go back to square one. She doesn't want that to re-injure. And the big thing for her was progressing those forces to where she's running on a more uneven surface. And then she would notice when she'd have to take turns, those kinds of things that she's being challenged in this, outside the sagittal plane. And I think that helped it click for her that, I need to do something that I have to do in this lateral stabilizing strategy to be able to load that. Because if I don't, me making these turns on trail runs and things like that isn't going to get any better. Because she could see the progress in, hey, if I just run on the track or if I run straight in the neighborhood, I'm fine. So yeah.
I feel like that's also a community as well that doesn't prioritize strength training.
Right.
Yeah.
or endurance community
Yeah.
in general.
Because I would even say people who bike and swim still do more, I feel like, than runners do. Because it's like you go do some squats or something like that. People are always afraid of like, oh, it's going to take out for my workout the next day and stuff
Yeah.
like that. And it's like, well, up front, yes, because you're like super sore. You haven't done it.
Yeah.
But if you stay with it, eventually like helps you running because you become more efficient. You're able to produce more force at the ground, keep your cadence, and what happens, your pace starts picking up. So it actually like over the long term starts to help. But yeah, up front, it's growing pains. I mean, it's nothing. It's just like anything else.
Yeah. And how many times when we were running was it we would continue doing our normal strength plan for the week at the beginning of the season, even though, we're going to be a little bit sore from it, but come towards the end of the season, taper that off, and you've got the benefit from the training over the last 3 months. But now you actually feel poppy when you're not doing those things for the last 2 or 3 weeks of the season.
And experience and goals matter. So like we're bringing Michael O'Neill, who's a local personal trainer here that just wrote a book to come on and talk about like hybrid training. I know we're kind of poking fun at it, or concurrent training is what it was classically called. But again, if I took, your patient, right, that at a certain point of life just wants to be able to continue running, maybe they drop into a race every once in a while, they're actually going to do better with concurrent training overall, right? That would be if you look at data or just like, anecdotal stuff, because you're going for a longevity play, right? Lean muscle mass is great for a lot of reasons, but also power output diminishes as we age. Versus if I want to be an elite runner, there is for sure a law of diminishing returns for strength training when you get further into a training cycle. Like you do have time trade-offs just from physiologic ability to adapt to training, but also like body mass. I mean, all these things come into effect, but like that's, I don't know how many people you guys have on your schedule for the next
Not
2
a
weeks.
lot.
That's any of those people. I have 0. Besides maybe our high school runner.
Yeah.
And we said last time he could actually use a little more muscle mass.
Oh, yeah.
Like he's too far on that side. So it's a dance, but like very rarely is like, oh God, I'm gonna miss my training. It's like the 2 days that you think you're gonna lose from that like aerobic capacity stuff, you gain like power output in general, I don't know, movement efficiency and muscular endurance.
Yeah, I'd rather her drop from 5 days a week to 3 of running, do 2 days of strength training. And if she gets to where she feels like she can do 2 days of strength training and one of those days she does a double where she runs and lifts, cool.
But again, think of the mindset that gets pounded into you from the time you're in high school. Then you coach people that are running, you're literally training them up, right? So they're even different than what you're doing, but a lot of times they fall into the same like schema, like they're running with their athletes, like, oh, I just do what they do. It's not quite the case. So like I said, we have a podcast coming out talking about that. I'm also, I don't know if it's going to happen. I'm trying to get Jason Koop on the podcast. So if you're familiar with who that is, probably, in my opinion, one of the preeminent endurance coaches out there. He's written same book, now it's 2nd edition, which is kind of thought of as the ultramarathon, training Bible. So get him on and he'll go into the weeds, but we'll try to make it more layman's terms when Michael O'Neill comes on. So that's coming up here pretty soon. Anything else? If you're, a doc, student, patient listening, and if you have specific areas you want us to address, because we're picking from our patient base, but if you're like, hey, I've had a consistent problem with this as a patient, or I see a lot of this as a doc, let us know and we can try to hit that. So you can email us, hit us up on social media. But as always, appreciate you listening, and we'll see you in 2 weeks.
Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.